Good afternoon and welcome to the Montana State University College of Nursing Center for Interdisciplinary Health Workforce Studies Spring Webinar Series focusing on the behavioral health workforce. We are pleased to have you all joining us for today's webinar. My name is Christy Friedman and I am the Program Manager for the Center. This spring series is co-hosted by the Behavioral Health Workforce Research Center at the University of Michigan School of Public Health and will run as a 4-part webinar series from February to May of this year. Please save the date for our next event in this series, titled Solving the Behavioral Health Workforce Crisis, Award-Winning Tools for Growing Your Pipeline of Providers, which will be held March 30th at 1 p.m. Eastern Standard Time. We also have a wonderful blog post detailing the genesis of this series and future dates to hold on your calendars if you visit our website at healthworkforcestudies.com. A few center announcements before we begin today's webinar. First, we've posted new quarterly RN employment data for the fourth quarter of 2016 to our website. The total employment growth of registered nurses shows that the number of full-time employed registered nurses decreased by about 48,000 since the third quarter of 2016, and is only the second decrease in total RN employment observed in the past 10 quarters. This suggests that the long-anticipated RN retirement is finally being observed in national survey data. We invite you to check out that information on our website. Second, we're also partnering with the Center of Health Workforce Studies at the University at Albany, State University of New York, and the Health Workforce Technical Assistance Center to organize webinars focused on state-level nursing data collection, analysis, and dissemination. The next upcoming webinar in that series, Using Nursing Workforce Data to Inform State Policy, will be held on February 22nd, 2 p.m. Eastern Standard Time, and focusing on research that uses nursing workforce data to support more effective state decision-making. The next upcoming webinar in that series will be 2 states' experiences using HRSA's web-based nursing supply and demand model, which will then be held on March 22nd, also at 2 p.m. Eastern Standard Time, and features the experiences of nursing researchers in 2 states using their own nurse supply data in HRSA's web-based nursing supply and demand model. You can RSVP for these events and read more about that upcoming series in an announcement blog post under the News and Announcements portion of our website. Also, in case you missed it, we have new RN regional forecasting research posted to our website titled, How Fast Will the Registered Nurse Workforce Grow Through 2030? Projections in 9 regions of the country. It is now available online and in the latest January-February issue of the journal Nursing Outlook. The purpose of this study was to understand how the outlook for growth in the future number of RNs over the next 15 years varies regionally across the U.S. We apply our nursing supply model to 9 U.S. Census divisions to produce separate supply forecasts for each region. We found dramatic differences in expected future growth of the nursing workforce across these regions. Again, visit our website for a direct link to the online article to read more. And finally, it's not too early to be thinking about summer 2017. Save the date and make plans to attend the 2017 National Forum of State Nursing Workforce Centers Conference titled The Nursing Workforce and Health Reform, Trends and Opportunities in a New Political Era. This conference is being co-organized by our center and will be held June 7th through 9th, 2017 at the Grand Hyatt Denver in Denver, Colorado. More details, including call for abstract sponsorship and registration information, are now available on the National Forum of State Nursing Workforce Centers website. That can be found at nursingworkforcecenters.org. Again, please visit our website for this and more information at healthworkforcestudies.com. After today's presentation concludes, we will have 15 to 20 minutes for discussion and question and answers. Please feel free to type any questions you have in the area designated for questions on your menu bar, and we will get to as many of your questions as we can. We are also recording the webinar today, and we'll have it posted to our website And we have posted all of our previous webinars if you missed any of our other series. You can also find presentation slides for many of the webinars posted alongside the recorded webinars. Now I'd like to take a minute and allow Peter Bierhaus, Center Director, to introduce our speaker. Peter?
Hey, thanks, Christy. I'm broadcasting from Bozeman, Montana, at Montana State University, where the snow is melting pretty rapidly. And in about another month, the grizzly bears will be emerging from hibernation. That's a whole other story and a whole other webinar. So we'll move on to the other one, the one of our subject today. And I'm really thrilled to be working with the University of Michigan and its Behavioral Health Workforce Research Center. Obtaining a better understanding of behavioral health workforce is so important for so many reasons. And I imagine that probably everyone on this webinar has been touched in one way or another, directly or certainly indirectly, by someone, a friend, a family member, perhaps themselves, with issues around behavioral health. And from my perspective, it's starting to feel that we're seeing behavioral health issues increasingly part of the media, the national conversations, and even in the political discussions going on around healthcare reform. So it feels like the time has finally come where we could have a more full and serious integration of behavioral health into our refining our delivery systems. So with all that, let me just introduce briefly Angela Beck, who has a PhD and also a Master's of Public Health, and is the Principal Investigator and Director of the HRSA-funded Behavioral Health Workforce Research Center at the University of Michigan School of Public Health. At the School of Public Health, Angela also serves as the Clinical Assistant Professor of Health Behavior and Health Education. She's also the Director of the Michigan Public Health Training Center, the Associate Director of the Center for Excellence in Public Health Workforce Studies, and Managing Director of the Office for Student Engagement and Practice. So Angela doesn't do a whole lot. She's got a lot of spare time. Dr. Beck has participated in workforce development programs and health workforce research since 2003, and that all started when she began her career as a Health Resources and Services Administration Fellow in the former Bureau of Health Professions. Since joining the U of M in 2005, Angela has served in management and research roles. She's conducted national studies on workforce size, composition, and characteristics of the public health workforce, nurses, epidemiologists, lab workers, and other public health disciplines. Her research now focuses on the development of a minimum data set, studies of characteristics in practice settings, and analysis of professional and legal scopes of practice for the behavioral health workforce. She holds a bachelor's degree in physiology from Michigan State University and a master's of public health and PhD degrees from the University of Michigan School of Public Health in Health Behavior and Health Education. So we're delighted to have you, Angela, to kick off this 4-part webinar series, and I'll turn the microphone over to you.
Great. Well, thank you so much, Peter and Christy, and many thanks to your center for sponsoring this webinar series on the behavioral health workforce. What I'd like to talk about today is start by giving you a bit of summary information on what we know about the behavioral health workforce in terms of size, composition, and some of the challenges with workforce development. And then I'll segue into providing a little bit of information about our center, the Behavioral Health Workforce Research Center that I direct here at the University of Michigan, and then talk some about some strategies that I think could potentially help strengthen workforce capacity and some of our study findings here at the center that kind of are associated with some of these strategies. But first, probably not a surprise to many of you joining this webinar, but the field of behavioral health is said to be in the midst of a workforce crisis, and this was a declaration that was made in a 2007 report released by the Annapolis Coalition. I mention this report every chance I get because I think it does such a wonderful job of laying out some of the real challenges associated with workforce development in behavioral health. Among them are increased demand for behavioral health services, so things like healthcare reform and mental health parity legislation have really driven the need for more mental health services and substance use disorder services. In general, we have too few workers, too few trained providers to meet that demand. And it's not just an issue of having too few workers. The workers that we do have tend to be poorly distributed. So we have an issue with maldistribution of the workforce, providers clustering in certain areas, leaving some communities with little to no coverage in terms of behavioral health providers. The workers that we have need additional training. So we've heard things like increased emphasis on integrated care and treatment of co-occurring disorders. This all requires skills that some providers perhaps don't have that are in the field. So we need to think about additional training needed. And I would say, speaking from a research perspective, behavioral health suffers from a real lack of systematic workforce data collection. And I'll talk about this quite a bit today because I think it's so fundamental to how we address workforce capacity in the future. But first, I want to start by saying a little bit about what I mean when I say behavioral health workforce, because if you look in the literature and you look across studies, you'll see different types of occupations noted when thinking about behavioral health. And most commonly, you will see this list of licensed professionals that are kind of considered the core professionals of the behavioral health workforce. So psychiatrists and psychologists, marriage and family therapists, certainly social workers, licensed professional counselors, and psychiatric nurses. But they aren't the entirety of the behavioral health workforce. And we also want to think about folks who are serving roles as addiction counselors, peer providers, which is becoming an ever increasing part of the behavioral health workforce and a really important one, and folks that are serving in direct care support professions. And certainly we don't want to forget about our primary care providers who are interacting with behavioral health either in a referral capacity or often trying to provide behavioral health services in communities where there are no trained behavioral health providers. So the behavioral health workforce in general, it's quite broad. One of the first things that our center talked about with its partners is how we wanted to define the behavioral health workforce for the purpose of our research. And we decided on a definition that's more functional in nature, in that we consider the behavioral health workforce anyone who's involved in prevention or treatment of mental health or substance use disorders. So really, regardless of the occupation, the licensure, the certification, perhaps no licensure or certification, if you're serving in a functional role that addresses mental health or substance use disorder, we're interested in you as part of the behavioral health workforce. Also, just wanted to say this slide is not an exhaustive list, and it's certainly not meant to imply that every behavioral health worker is either licensed or certified. They're not, but much of the workforce occupations have some option for licensure or certification in many states. So to talk a little bit about behavioral health workforce supply, the data on this chart are mostly pulled from the Bureau of Labor Statistics, which collects data on lots of standard occupational classifications across many different industries and sectors. These are the standard occupational classifications that most closely relate to behavioral health, or that you would look at and say, yes, this looks like a behavioral health worker. It doesn't tell us much about the education or the training or the licensure or really what these folks are doing, but they're identifying in an occupation that looks to be relevant to prevention or treatment of mental health or substance use disorders. As you can see, much of these reflect those core licensed professions. So we're looking at different classifications of social workers and counselors, psychologists, psychiatrists, and so on. The blue bar is the only standard occupational classification that looks at more of an aide or technician role. So you can see, again, in terms of data collection, it's far more focused on that segment of the workforce where we can track licensure and so on. In total, with the occupations listed on this slide, we're looking at about 930,000 or so behavioral health workers. Again, they represent a segment of the behavioral health workforce, but this is one way to try to look at behavioral health workforce supply. I chose to use BLS data in the last slide, but there are other ways certainly to collect behavioral health workforce data. You could look at things like licensure. You could look at membership surveys of different professional organizations, national sample surveys, or work that other universities are doing. The challenge with the multiple types of data sources is that you will get quite varied estimates of workforce size depending on what you're looking at. This table is taken from a report released by the Congressional Research Service, and it's trying to take you through this idea that workforce size estimates vary by the type of data source you're looking at and the type of mental health provider. If we look, for example, in the middle here at clinical social worker, you could have workforce estimates that range from 115,000 if you're looking at BLS source data to 245,000 if you're looking at other types of data sources. So you can imagine the challenges as someone interested in, folks interested in workforce planning or projecting supply and demand. It's really important to understand that the numbers that we see can vary quite a bit based on different methodologies, different definitions of who you're including in your workforce population, and just a real lack of standardization when it comes to data collection across the field. This is a report that was released by HRSA last fall that tries to get at some of these behavioral health workforce projections. Looking forward to 2025, HRSA chose 10 occupations related to behavioral health and used their simulation model to try to look at what supply and demand might look like in 2025. And you can see here that really across nearly all of the occupations they chose to include in this study, we're looking at shortage in 2025 where demand exceeds supply. Behavioral health nurse practitioners and behavioral health physician's assistants are a little bit on the surplus side, but certainly not much. Overall projected supply in 2025 for these 10 occupations is somewhere around 883,000, which is short of the demand that is projected by well over 250,000 workers. So, you know, as I mentioned, if in 2007 the Annapolis Coalition was kind of alerting us to this workforce crisis, I don't think this report gives us any confidence that we're kind of alleviating that at this point. You know, we're still looking at pretty substantial concerns related to the number of providers in the behavioral health workforce. I also alluded to a problem related to workforce distribution. This map is pulled from HRSA's data warehouse, and it shows in blue the areas that are considered mental health professional shortage areas, or HRSAs. HRSA estimates about 4,000 mental health HRSAs in the country. HRSAs can be defined in a couple of different ways for mental health, but the most common, perhaps, definition looks at a psychiatrist to population ratio. According to these data, approximately 2,800 more psychiatrists are needed to kind of address this, this shortage nationwide for behavioral health. This represents an increase, actually. In 2012, HRSA was showing about 300 fewer HRSAs across the country, as well as a need for about 1,000 fewer psychiatrists to alleviate shortage. So again, we're kind of seeing ourselves going in this direction of needing more providers and being very concerned about distribution of the workforce. 55% of U.S. counties, predominantly rural, have reported having no practicing psychiatrists, psychologists, or social workers. So certainly this is an issue that extends beyond psychiatrists and is important to think about when thinking about the behavioral health workforce as a whole. So if I were to summarize the state of the behavioral health workforce, I would say again that the behavioral health workforce is quite broad in scope. We're talking about lots of different occupations and levels of training, different scopes of practice and authority, and different types of functions of the folks involved in delivery of these services. Despite the breadth of the behavioral health workforce, research efforts have been primarily focused again on those core licensed professionals. We know that there are supply challenges, right? We know, we have data showing that there are too few, we have data showing maldistribution, but we have lack of data on the full workforce, so that makes shortage really difficult to determine. You have to know what you need to be able to project shortage, and if we're not looking at the whole behavioral health workforce and how those different types of providers are working together to provide care, our projections are going to be limited. Overall, I think focused research efforts can help inform some strategies for addressing behavioral health workforce capacity, and that's really what our center at the University of Michigan is trying to do. So a little bit about our center. The Behavioral Health Workforce Research Center was established in September 2015 at the University of Michigan School of Public Health. We're part of HRSA's Health Workforce Research Center network. We're a little bit unique from the other centers in a couple of ways. We're the only center that's solely focused on behavioral health, although there are other HWRCs that do wonderful work in this area, and we're so lucky to have them as collaborators and partners. Our center is the only center that's jointly supported by HRSA and SAMHSA, so we have great folks at both of these agencies who are helping guide our research agenda and giving us wonderful feedback along the way. Our center works through a consortium model, and I will introduce our consortium partners to you in a moment. And we also feel strongly that it's important that our core research team be interdisciplinary in nature. Our faculty investigators represent public health, medicine, law, social work, and our research staff, a team of 4 there, very dedicated folks who really help ensure the center meets its deliverables and its goals. This is a list of our partners of our center, and certainly Peter, front and center here, is a key consultant to our center, as is Ron Manderscheid. And I just have to say, between Peter and Ron, the wealth of knowledge and the subject matter expertise in behavioral health and health workforce between the two of them, our center greatly benefits from that. The organizations in the yellow box represent our partner consortium. And you can see here that it's diverse in representation, different types of disciplines represented on the board, both mental health and substance use and addiction, and as well as our public health partners. And again, our federal partners are HRSA and SAMHSA. The work of our center is structured around 3 focus areas, and these focus areas were determined by HRSA and SAMHSA. They involve the development of a minimum data set, doing studies on workforce characteristics and practice settings, and also looking at scopes of practice for behavioral health workers. We're contracted to do 12 research projects per project year. We just finished year 1 back in September. So we have findings of those projects. We are in the midst of our 2nd year, so in the midst of conducting the next set of 12 projects. I certainly don't have time to go through all 24 projects in this webinar, but the bullet points here are meant to kind of give you a sense of the breadth of the topic areas that we're looking into as part of these focus areas. If you're interested in seeing more details on our studies, please do visit our website, behavioralhealthworkforce.org. We have a page for each of them that kind of outlines a summary and our study design and so on. What I'll do now is kind of talk about some different strategies for strengthening workforce capacity, and I'm going to highlight some research findings from one study in each of those focus areas. So when I think about strategies for strengthening workforce capacity in behavioral health, a couple of things came to mind pretty early on. Behavioral health is a bit of a new area for me. As Peter mentioned, my background is really more in public health workforce studies. But a lot of applicable methods and research challenges and so on between public health and behavioral health. But even as I'm getting to know behavioral health better and better, these strategies seem to pop out pretty early on. So one involving better workforce data collection to inform planning efforts, and I'm sorry you'll hear me talk about this quite a lot because I think it's so important. Also embracing best practices. So I'll highlight some findings from a qualitative study we did on team-based care in behavioral health. and also looking at scopes of practice, so assessing and refining potentially legal scopes of practice. So the first strategy is around data limitations impacting workforce planning. So I've already spent some time kind of walking you through some of the limitations with the data that we have in terms of not having great data on the full behavioral health workforce and the variability in things like workforce size estimates across different types of data sources. One of the main projects HRSA and SAMHSA asked us to complete in our first year was to work on the development of a minimum data set for the behavioral health workforce. And minimum data set that is not a new concept. Actually, HRSA's been working on this for quite a while. If you Google HRSA minimum data set, I'm sure you'll come up with this website that I have a screenshot of here, where you can take a look at minimum data sets that have been developed for other health professions. And actually, there are a few behavioral health professions included within that list. Our job was to develop a minimum data set that would speak to that entirety of the behavioral health workforce, so going past those core licensed professions and including anyone who really is functionally involved in mental health or substance use disorder treatment and prevention. The purpose of a minimum data set is to really identify what are those common data elements we need to know about the workforce to better inform workforce planning and to improve consistency and comparability of behavioral health workforce data collection and use across these different studies and different mechanisms for collecting data. If you've never seen an MDS, there's a little screenshot of a draft of ours here. It kind of looks like a survey tool. It's not meant to be a survey tool necessarily in itself, but a set of questions or data elements that researchers or licensing boards or anyone else collecting data could pull into their survey and to ensure some consistency across studies. What we did as part of this minimum data set project was to think about first, what are the main themes in terms of data collection that we need to know about the workforce. And we came up with 5, and they focus on demographics, education and training, licensure and certification, occupation and area of practice, and then workforce characteristics and practice settings, and kind of the functional tasks fall into that last area. So we have data elements, several data elements within each of these themes to kind of build out this minimum data set. Our minimum data set was approved by HRSA and SAMHSA within the last few weeks. So if you're interested in seeing the full instrument, it's available on our website. The other piece of our minimum data set project that we completed in year 1 was to take a look at the workforce data sources that exist currently and try to figure out whether there's some mechanism, understanding that there are differences in methodologies and limitations across different studies, but is there a collection of studies that could get us the data for all of these elements that we think are important for workforce planning? Or are there data gaps? Is there a need for new primary data collection or a need to modify data collection that's currently ongoing? We identified about 150 behavioral health workforce data sources, some state-based and some national in scope. And what we did is take a look at those data sources and the variables included in them and work on mapping them to those themes that I mentioned that are part of the MDS. For the national data sources, we also took a look at things like validity, reliability, the frequency with which the data are collected, and the accessibility of the data. Are they publicly available or not? Just to try to get a sense of, could we kind of count on these national data sources as a mechanism for getting the information we need? This is an example of how we went about this project. So this is just a screenshot of our little snippet of our database where we're kind of looking at the data source and trying to map it to things like, does it include a full enumeration of the behavioral health workforce that it's focused on? And then you see these MDS data elements, or these themes around demographics and education and occupational category and so on. For the state-based data sources, we didn't look so much at data quality or try to map it to the MDS. What we were more interested in is just getting a broad overview of whether states are engaged in this type of data collection. Are they trying to keep track of their behavioral health workforce? This map shows the number of data sources on the behavioral health workforce that we found in each state. So there were a couple of states where we couldn't locate a data source that was specific to the behavioral health workforce, but by and large, most states had at least one. And I would say West Coast and Pacific Northwest, we found sort of the highest concentration or the most state-based workforce data sources in that area. So overall, in thinking about addressing workforce data limitations, what we found through this project is that through those national data sources, we really do not have, certainly don't have a single data source, but also could not find a combination of data sources that would provide all of the information that we feel is essential for behavioral health workforce planning. We do feel like the use of an MDS, a minimum data set, can help with this issue of data standardization and quality. We think it's unlikely that there's going to be sort of a national source for data collection in the near future. As much as we appreciate the wonderful support of HRSA and SAMHSA, we're not funded to a level that would permit us to sort of be a national sampler or a national data collection source for the behavioral health workforce. So instead, trying to think through how we might be able to provide technical assistance to state organizations or local organizations who are interested in this type of data collection work may be something that we can do. We recognize that licensing boards have a big role in data collection. In fact, some make the case that they are probably the best mechanism for implementing an MDS, but we also recognize that licensing boards are often limited in terms of resources and infrastructure and ability to kind of change their data collection mechanism. So are there ways that we can work with licensing boards or other bodies to think through, now that we kind of have determined what these data elements might be, how do we move toward implementation? So the next strategy that I wanted to address has to do with best practices around team-based care. When we think about integrated care, as we were developing this project, we were thinking about integration both of behavioral health and primary care services, as well as integration within the field of behavioral health, so mental health and substance use disorder services, which folks told us, they ran into barriers with, even excluding primary care just within behavioral health. We know that integrated care has been shown to have lots of benefits in terms of increasing access to services, improving patient outcomes, decreasing costs. Overall, the general assessment seems to be that the field supports the idea of integrated care, but we kept hearing about these barriers to adoption and different ways that integrated care could be implemented. So our center did a qualitative study over the last year that looked specifically at team-based care as a mechanism for integrated care delivery. We chose 8 health systems that had integrated, who had implemented integrated care in some fashion, some type of team-based care. And the interviewees generally were leaders of the organization or perhaps clinical professionals. Our interview themes included things like, what is the composition of your workforce that's engaged in this type of integrated care? What do your workers think about team-based care? Have they given you feedback? What's the level of satisfaction with working in this type of service environment? We asked about things like workforce development and training initiatives around team-based care, and then, of course, these barriers and best practice. So, as you can see, there have been a lot of studies done on integrated care. Our center was really more interested in sort of a workforce lens and the workforce factors that are driving this implementation of team-based care. So today I just want to highlight for you some of the barriers and best practices that we found. These were the top 5 barriers to implementation that we elicited through our key informant interviews. And we have some blue boxes here that kind of pull out some quotes that emphasize these points. But number 1, folks told us that clinicians may initially be resistant to integrating or transitioning to a team-based care model, in part because they lack knowledge about how this all works. Leadership was telling us that by and large, folks are not learning this in school. They're not learning about how to work in a team-based model as part of their formal education or training. So there's a lot of work to do on the part of the organization to get folks' frame of mind around this. People talked about an insufficient number of providers. You can't have team-based care if you don't have a team, right? So going back to this idea of clinician shortages and really across multiple provider types, trying to find enough people that you can pull together to complement each other in a team-based model. There were difficulties noted in record sharing, particularly for patients with substance use disorders, so difficult to integrate care when there were barriers in what type of information could be shared. The next one had to do with administrative or workflow concerns. So a lot of talk about not having this physical space for co-location, and in some cases even having co-located providers but not having an effective mechanism of kind of having that warm handoff or linking those providers in an efficient way. And finally, lack of financial support for integration came up a lot. So things around billing and reimbursement obstacles. I think we've seen recently that there perhaps is some legislation that will help with some of these issues around, sharing of patient records, as well as some of these concerns about reimbursement. So hopeful that some of these barriers can be addressed in the near future. So as we talked to our key informants, they listed all of these barriers, but boy, they found a way to get around them. So we were interested in what they felt were the best practices were for overcoming these barriers. And a couple of themes came up pretty regularly. One, important to get buy-in from your leadership and your providers at the beginning. So this idea of working together to develop what this team-based model might look like, as opposed to structuring one and imposing it on folks, as sort of a top-down way of doing this. There was a lot of emphasis around needing to help providers understand how they can be collaborative. Scope of practice came up a lot in this, in terms of providers being uncertain about whether others should be doing certain responsibilities or feeling that like that was the responsibility of their profession, not someone else. So there are definitely some scope of practice and authority issues to work through when going down this road. We were told that it's important to be clear about the benefits with providers when trying to implement this type of service delivery. By and large, providers seem to report that after they started the team-based care models, their caseloads often felt easier to handle when there was better collaboration, that they felt that their patients were getting better care, better access to services, and responding better to treatment. So kind of leading with these benefits of integrated care as you try to pull the providers into this was really important. And again, this idea of in-house training, that most providers are not learning skills for team-based care implementation in their degree programs. So needing to have a very strong orientation or type of training to get providers on the same page around this. And finally, the last strategy that I wanted to highlight has to do with the scopes of practice idea and how it impacts workforce capacity. Over the past year, our center looked across the 50 states at legal scopes of practice, as well as professional scopes of practice that may describe different responsibilities or capabilities of different types of occupations. We were interested in the idea of this misalignment between scopes of practices among behavioral health professions and what folks were actually doing. So sometimes these are driven by legal restrictions that are imposed by states. Sometimes they reflect billing restrictions for certain types of services for certain providers, and sometimes they are associated with these guild issues or protection of legal and functional authority by professional groups. So the purpose of our project was to review every state's statutes, administrative codes, certification programs, and job classification materials to find scope of practice language for 10 behavioral health professions, and we have those listed there in the yellow box. Again, we have certainly included those core licensed professionals, but trying to move past them as well to include addiction counselors, prevention specialists, psychiatric rehabilitation specialists, and psychiatric aides. Once we identified all of these documents, we worked on extracting certain types of information from them and kind of coding them into different variables. One analysis was sort of a summary analysis that looked at things like the names of the certifying and licensing bodies across the different occupations and states, the published dates of statutes and rules, how often are they updated, professional definitions used for each occupation across all 50 states. Another set of analyses looked at licensure requirements. So looking at things like requirements around supervised work experience, examination requirements, continuing ed requirements. We also looked at issues like reciprocity across states. And finally, we were very interested in services that were authorized by scopes of practice. So by each state and occupation, we were looking at things like legal authority to engage in activities like diagnosis or crisis intervention or psychotherapy. As you can imagine, we have a really large database when you think about 10 professions across 50 states with all of these different types of variables. Some key findings that kind of pop out from our analysis in the folks that are kind of not as part of that core licensed professional group, we found that it was difficult to find scopes of practice. You know, we expected that we wouldn't find legal scopes of practice for some, but we expected to find professional scopes of practice for all, and in some cases we couldn't in some states. For the paraprofessionals as well as addiction counselor professions, it was clear to us that this is an under-researched segment of the behavioral health workforce. There was evidence of overlap of job responsibilities as well as inconsistency in job tasks across different types of job titles. So a lot of work to do in trying to sort of standardize who's part of these professions, what are they doing in an effort to sort of categorize and quantify these types of workers. For the core licensed professionals, we found that some states explicitly deny authority to diagnose patients for some of the licensed professionals. We also found things like marriage and family therapists were most likely to have education requirements outlined in their scope of practice. In fact, 49 of the states did that for marriage and family therapists. 48 of the states did that for mental health and addiction counselors. So some variability across occupations in terms of how explicit the education requirements are. And as part of our studies, we also found billing and reimbursement variability that exists under Medicare and Medicaid for behavioral health services. So some professions being unable to bill for certain services depending on the state that you're in. So in summary, if we're looking broadly across these strategies, I would again reiterate one core strategy would be to focus on this need for better data to address workforce size and composition problems. We'd also be interested in addressing barriers to adopting best practices, so things like payment mechanisms for reimbursement, ensuring proper training for integrated care teams, and then finally considering what factors may be limiting scope of practice and what can we do to address those. There are certainly other workforce development challenges and opportunities that I haven't highlighted that are of importance, and our center is kind of slowly working into getting into some of these areas. But recruitment and retention of workers is a huge issue, certainly in the rural areas, but I think just in general. It's a high turnover field. We have an aging workforce, and again, rural areas really have difficulty with recruitment and retention. It's important to ensure a more diverse workforce. We will be starting some studies around workforce diversity this year. And need for more specialized training for serving special populations. That came up as a theme in the literature and an area that we would like to do more work around. So in terms of our future directions for the center, we'll continue to focus our work along several themes. We're very interested in studies that look at service delivery for vulnerable and underserved populations. We'll be focusing on behavioral health workforce providing care in correctional facilities this year as an example of that. So really different types of populations that may be struggling with having adequate providers to provide care. We're interested in workforce factors that impact service delivery, so looking at things like telemedicine and other strategies for improving access to care. And we'll certainly keep doing discipline-specific studies. So we've kind of started with a list of occupation types that we've focused on over the last year and a half or so, and we look forward to working with additional provider groups. Overall, our center is very interested in producing research findings that inform policies to strengthen behavioral health workforce capacity, and hopefully with the collection of studies that we're putting together with our consortium partners, we'll be able to do that. This is information for our center. Again, that's our website. All of our projects are listed there, as well as policy briefs and full reports that have been completed for the past year. So we encourage you to visit our website, to follow us on Twitter and Facebook if you'd like to stay informed on our research findings. That's it.
Great, thank you so much, Angela. That was a wonderful presentation. And as I mentioned before, we are going to take some questions and answers from the audience. If you will type those in the questions area of the menu bar, that would be great. We also welcome comments, but just for ease of understanding your comment and how you'd like the speaker to respond, if you could frame your comment with a question or something that would help us understand how you'd like Angela to respond to your comment, that would be great. So I'll give you a minute just to do that. I do have a couple of questions here already as people are filling those in. So Angela, you mentioned several areas where research is needed to inform behavioral health workforce planning. If you had to choose one as the priority area, what would that be?
Well, I hate to sound like a broken record, but if I had to choose a priority area, I think the data piece really is the requisite area to inform the rest of the areas. Without good data, good reliable data, we're somewhat limited in what we can do for the rest of it. So if I had to choose a priority area among those strategies, it would probably be related to addressing some of the data limitations for the behavioral health workforce.
Great. I have another question here. This is a housekeeping issue. I have several people looking for slides. Would it be okay to share the slides on the website after the presentation? Okay, yeah. Great. I'll make lots of people happy. All right, let's see. Where did my question go? Okay. In the HRSA-sponsored UNC SHEPS Mental Health HRSA project, we used a methodology that differentiated prescribers from non-prescribers. We found that the lack of availability of prescribers may have set a ceiling on local availability of services. Is this still a helpful distinction in understanding how different workforce scopes of services might affect availability?
Yeah, I think it can be, and I think that's really great work coming out of SHEPS. We're using a similar model in looking at a study this year around medication-assisted treatment and looking both at prescribers and non-prescribers and how they can interact to ensure service delivery. So yes, I think it is a useful distinction and probably not one we've used enough in our center, in terms of our analysis, but one we're working toward. Great.
Have you considered using community health workers as part of the team-based care and collecting their data?
Yes, yeah, that's a great question. We would love to include community health workers. We've done so in a couple of our studies. Again, data collection around community health workers can be a challenge, although there is a standard occupational classification for community health workers. The difficulty becomes figuring out in what function they have, what role they're playing in the workforce, because their work can be quite varied. But it's an excellent idea and an area that we would like to pursue.
Great. One of your slides forecast behavioral health workforce shortages. Other than psychiatrists, I'm not aware of any HRSA or related ratios for other behavioral health professionals. How do you recommend we calculate supply shortages?
That's a really good question. That's actually something that our consortium has tasked us with for our next project year. So a very timely question. I'm afraid I don't have all of the answers for that today, but that's definitely on our agenda, and we've had some discussions with our HRSA and SAMHSA project officers already about whether that would be useful. Again, I think it comes down to trying to identify first what are the reliable data sources that we have to base these sort of estimates on, and moving from there. So we're laying the groundwork for it, but we're not quite there yet.
Another one over here. Do you know of models across the country for successfully recruiting to rural areas? At the University of Montana, we have a rural behavioral health integration project, and recruitment to rural has been a challenge.
Let's see, I don't know of any off the top of my head, but what I will say is our next webinar in this series should get into some of that. The folks at the University of Nebraska are very engaged in this, and they will be talking about some pipeline and some recruitment issues specifically around this area. So I'm hoping that they can help me out by elaborating on an answer for you for that.
I have an offer of help. Just an FYI, in Minnesota, we track our behavioral health workforce very closely and have quite a number of data sources. Let me know if you would like more information. So I will encourage this person to reach out to you if you would love to hear about Minnesota's data.
That's wonderful. We'd love to hear about Minnesota's data, yes.
Okay. All right. Oh, here's a good question. How does telehealth fit into building teams in behavioral health? And are you finding outcomes to be improved by the use of teams using telehealth?
That's a great question. We're actually in the midst of our telehealth study right now, so we don't have findings back yet. When we did our team-based care studies, we did not specifically ask about telehealth as part of those case studies, and we probably should have. It did not come up as a common theme in the interviews. So I don't have any specific findings for you around that yet, but I hope to when we wrap up this project on telehealth later this summer.
Great. What advice would you give to a college student majoring in psychology to do to get a job that will lead to a future career?
No, I'm probably not the best person to advise on that, but we certainly have folks in our partner consortium who could. So if that person would like to contact me after, I have some folks I can connect you with who would be better suited to answer that question than I am.
Looking for a place in rural areas might be a great
yeah, I would say rural areas is a really good start.
All right. Has there been any investigation or research of preceptorships for the behavioral health professions?
Not by us, although we are working with the American Psychological Association this year on a project that is going to look at recruitment and retention of a diverse behavioral health complement in doctoral health service psychology programs. And as part of that, we're going to get into that a little bit. It's very narrow, you know, it's just on psychology programs, but can hopefully start to give some findings around that. It's not something that we've looked at broadly across the behavioral health workforce.
Great. Will you be including the RN workforce in your data collection?
Yes.
That's of near and dear to many people who,
yes,
who follow our webinar series.
I guess I would also plug the last webinar in this series will be around psychiatric nurses as well as other aspects of the RN workforce in mental health.
Yes, and we have just for reference for anyone who's listening to be able to plan for some of these upcoming events. All of the dates are listed in the blog announcing our series right there on the homepage of healthworkforcestudies.com. So if you're looking to go ahead and mark your calendars, those dates are up and posted. All right, so what specific issues related to the public awareness of the opioid epidemic provide the opportunities for health workforce researchers to highlight the role of and need for behavioral health workers?
Sorry, can you give me that one more time?
Sure. What specific issues related to the public awareness of the opioid epidemic provide opportunities for health workforce researchers to highlight the role of and need for behavioral health workers?
Yeah, I mean, I think certainly the opioid epidemic clearly is very salient. You see it in the media a lot, and I think it has been a useful mechanism for highlighting the shortage. From what I have seen, there has been quite a bit of attention around the need for more providers, the need for more prescribers, essentially, around opioid treatment. So, you know, I think in terms of specific issues, I think anything that draws attention to our field can help us, frankly. You know, opioid has certainly done that in recent months. So, you know, I guess I would just say that the media attention is useful in highlighting the shortage, I believe.
Oh, great. Well, we're coming close to the end of our time. I'm going to give you one last one here. Much of the research clearly seems to focus on the core licensed behavioral health professionals. What are the best mechanisms for including peer support and paraprofessional occupations in these studies?
That's a great question. That's certainly something that's of a primary focus for our center. We really think that's key. There is work going on around peers and paraprofessionals. I don't mean to make it sound like there isn't. I think and it's good work. The challenge is the lack of resources or investment or infrastructure around those pieces of the workforce. So I guess the only thing I could say that the best mechanism might be to advocate for more funding, for more research opportunities, to include those segments of the workforce and some of the other national work going on, that we not just limit ourselves to the licensed occupations.
Great. Well, thank you so much, Angela. Peter and I are both very excited to get this series kicked off and to keep going and looking at the behavioral health workforce. So that will conclude our webinar today. Thank you all who have attended with us, and to everyone who is new to joining our series. I noticed we had a lot of new faces this week. So please save the date for our next event, Solving the Behavioral Health Workforce Crisis, Award-Winning Tools for Growing Your Pipeline of Providers, which will be held March 30th, 1 p.m. Eastern Standard Time. Thank you all for coming.